Good morning, everybody. Thank you, as always, for joining. Just giving it a moment, as I always like to say, I'm trying to kill time just for a moment to see participants getting into the stream today. We have a really nice presentation as well as presenter with us today. We're really excited to welcome her. Before that, we just have our usual updates. We don't have too many updates, at least from the typical COVID stuff that we've been doing forever now. We will continue to have COVID updates as needed, but it's always nice to not have them. It's usually a good sign. And many of you have probably seen numbers have come down really nicely with all respiratory viral infections throughout January. So one of the reasons we don't have much updates is because things are better in that regard. But please do, as I mentioned before, please do send me a message if there's anything you'd like to see in the Grand Rounds updates at the beginning that we can cover. I love hearing input from others. One of those inputs I've been hearing, speaking of segue, is I've had a lot of requests to comment on everything that's been going on in around Turkey and Syria border with the recent earthquakes. I've reached out and Dr. Michelle Berry has also given some advice on that, and she's been working as always when there's something going on in the world with various groups. There is a link of a number of factions within Stanford, like the Stanford Turkish Students Association, working on the places to donate. I'll send a link that has a summary link of the news and options to donate, and many of those do one-to-one matching contributions as well. So I'll send that out, and we'll make sure it's in the follow-up emails for Grand Rounds, as well as our next weekly newsletter as well. If there's any other input as far as how to address things like that ongoing one or anything else, again, please reach out to me. I love having that feedback. That being said, I'm going to now turn over to Dr. Dunn. As you see, we're celebrating Black History Month. We have a lot of great things lined up, including today. Thank you to Dr. Dunn and our leadership to helping make this month a really great celebration. So Dr. Dunn, thanks so much. I'll turn it over to you.
Thanks so much, Dr. Ozdalga. Well, first of all, happy National Black Women Physicians Day within this month of Black History, where we celebrate Black history and Black contributions. I wanted to just let you know about a few upcoming events that we have in store for you for this month. You still have time to listen to the 1619 Project, episode 4, How the Bad Blood Started. We will be discussing that. Dr. Salas and I will be leading that discussion tomorrow, February 9th at 5 p.m. Pacific. That's going to happen on Zoom. You can scan the QR code that you see here, or the link will be placed in the chat. We hope to see you there. Again, this is one of the episodes that's dealing with healthcare, so it's especially pertinent to our community. And how we are striving to become an anti-racist department. So next, I will tell you that, next slide, please. We also have the remaining part of our Black Speaker Grand Round series happening next week. We will welcome Dr. Kevin Alexander, followed by rounding up the month on February 22nd with Dr. Atube Essien. So we hope you will join us for all of those as well. And finally, I wanted to let you know that we will be having an African drumming group called Kumba join us for a reception in the Dean's Lawn in front of Allway. That's going to happen on February 28th at noon. There will be treats, there will be Black Joy, and we hope that you will be able to join us for that. They are called Kumba, and there's a registration link in the chat now. Thank you, Dr. Harmon. And with that, I will turn it over to Dr. Schulman, who will introduce our speaker.
Thanks, Dr. Dunn. It's really a pleasure to introduce Linda Villarosa, award-winning journalist, author, editor, novelist, and educator. She is a contributing writer for the New York Times Magazine, where she covers race, inequity, and health. She was editor of the health pages for the New York Times for several years, previous editor of Essence Magazine, and also a contributor to the New York Times 1619 Project, so very appropriate. She's a graduate of the University of Colorado, did a public health journalism fellowship at Harvard Chan School of Public Health, and is a recipient of a master's degree in urban journalism and digital storytelling at City University of New York. She's won numerous awards, including from the American Medical Writers Association, the Arthur Ashe Institute, Lincoln University, New York Association of Black Journalists, National Women's Political Caucus, the National Lesbian and Gay Journalists Association, and the Cali Lord Community Health Center. She is the author or co-author of 3 books, including Body and Soul, Black Women's Guide to Physical Health and Emotional Well-Being, a novel, Passing for Black, which was nominated for the Lambo Literary Award. And today she's here to talk about her 2022 book, Under the Skin, The Hidden Toll of Racism on American Lives and on the Health of Our Nation. A really powerful, intimate and personal story that puts the data that we've been talking about and talked about last week in Grand Rounds in a very personal perspective. So Ms. Villarosa, thank you so much for joining us today and really looking forward to your remarks.
There we go. Good morning. I am so happy to be here with you. I'm really impressed by your robust Black History Month offerings, and thank you for inviting me. Dr. Schulman, thank you for all you've done for me. Kevin was a really big help for me in a lot of ways, but including his research, which I discussed with him. We went back in time and talked about it when he was looking at the way Black patients are perceived. And we talked about all the things that happen around it. And it was really instrumental for me and foundational for me to understand your work. Well, I'm going to start with a quote from Martin Luther King that's very familiar to us. And it is, "Of all forms of inequality, injustice in healthcare is the most shocking and the most inhumane." And I'm going to, for this session, I want to correct that quote. A couple of years ago, there was it was reported in newspapers. It was in 1966 in March that Dr. King said that. But someone went back and looked at the recording of him and actually corrected the quote. He actually said, "We are concerned about the constant use of federal funds to support this most notorious expression of segregation." So that part gets cut off a lot. And he actually said, "Of all forms of inequality, injustice in health, not healthcare, is the most shocking and the most inhuman, not inhumane, because it often results in physical death." And that to me says it all, and actually says more. That it's not just the reason you see racial health disparities in this country is not just because of what happens in the healthcare system, but what happens in society. And it affects not just healthcare, but health. And it's not just inhumane, it's actually inhuman, which makes it worse. So that I hope sets the stage for my talk today. I'm really excited to share with you. Okay. The basis of my book and the things that got me the most mad was looking at America and how wealthy we are, that we're the wealthiest country in the world. We spend more on healthcare than any other country, which is about $12,000 per person per year. Yet money doesn't buy us good health in this country. We have the lowest life expectancy, the highest rate of avoidable deaths, the highest COVID death rate, physical assault, and most alarmingly, the highest rate of infant and maternal deaths compared to other wealthy countries. But when we talk about this, especially, I started at Essence as the health editor about, 30 or something years ago. So I've been thinking about this a long time, and I've been asking to understand it. And it's sort of like, why are our poor health outcomes relative to other wealthy countries so bad? And often there's confusion around what the answer is. And it's sometimes even treated as a mystery. Obviously, if we had universal health care, if we had a more equitable healthcare system, that would certainly help the problem. It would help put us on par with some of the other wealthy countries that do better than us and spend less money. But it would not totally solve the problem, especially when it comes to what I care about most and what I write about in my book. And it's about the health outcomes of Black Americans. It starts at birth, where Black parents have about over twice the rate of infant mortality. It goes to maternal mortality, where Black women are 3 to 4 times more likely to die related to pregnancy, childbirth, and the time after. And then when you look at Black birthing people, Black women, you see, and if we were our own country, our rates of maternal mortality would be higher than other much poorer countries. Yet, when you look at the explanation for racial health disparities in health outcomes, it usually comes down to only generally 2 things: poverty and lack of access to healthcare. And in conversations like this, we often talk about, like, the sort of misquote of Dr. King, healthcare, and how the healthcare system is to blame. And I certainly take, I come to you humble. I'm not a physician, but I have looked at this a long time, and I never want to feel like I'm walking into this room saying, oh, talking at you like you're doing so many bad things, when I have there's so much value to what you all do, and as healthcare providers, and I know it's hard work and it's important work. But when you have these conversations, and I had one recently, it was sort of like folks from the community talking about how they were perceiving their care, and then healthcare providers from the hospital in this area. And it was such a disconnect, because all the healthcare providers were saying, oh, we just need more access to healthcare, and that would solve these problems. And the people from the community were saying, no, we're scared to go into the healthcare system because we haven't been treated that well. So while one was saying lack of access to healthcare, people were saying, well, we're not necessarily lacking access. We are afraid of the system and we're not treated well within it. And then the other way to explain these racial health disparities has been around poverty, which certainly is a crisis and a problem in this country. And, it contributes to bad health. Yet it's not the only explanation. And here's how I think of it is Black people, about 20% of us are impoverished in this country. These are pretty recent stats, and we're worse than most of the other groups, all the other groups. Yet I was born in 1959, and when I was born, the poverty rate among Black people was 60%. So that meant 60% of us were living under the poverty line. By the time I was in middle school or the end of elementary school, after the civil rights movement, that number had dropped to 40%. And now it's dropped in half since then. So it's been plummeted. There's no doubt that there's been a robust rise of a Black middle class and an educated Black class. Yet the racial gap in health outcomes has not improved. So as poverty rates have gone down, racial gap in health outcomes has stayed basically the same. There's never been a time in this country where we had equal health outcomes to white people. All right, but this is the statistic that really got to me. This is the one that made me think differently. And this says that a Black birthing person with an advanced degree is more likely to die than her white counterpart with an 8th grade education. And I think when you look at this, the gap is wider at the more educated level. So why would it be access to education sort of as a proxy for access to good health, to living in a community where you have a good hospital system, or where you at least have access to a good physician, healthy food, what to do for your prenatal care? So why would the gap be so much larger at the more educated end? And that's what got me really started to look into the issues that are core and foundational in my book. Like, why is race alone a factor in the poor health outcomes of African Americans in this country? All right, so I started looking into it, and I went back in time, mostly around infant mortality and to some extent maternal mortality. And the first explanation, especially with infant mortality, is it genetics? Are Black bodies somehow different from white and other American bodies? So is it genetics that is to account for racial health disparities, especially in infant mortality? And I was looking back, and in the first half of the 20th century, we had so many advances in newborn intensive care and all that, the kind of thing that keep a small baby alive. And our rate dropped as a country. Our rate of infant mortality dropped. But at the same time, why did the gap in infant mortality widen, actually? Why did the racial gap widen? And there became this, in the, at the same time all of this was happening, there became this quest for a preterm gene. And I also worked on the 1619 project, so I'm glad you're going to discuss that tomorrow. And when I went back in time and looked at physiological differences in Black bodies versus white bodies to explain racial health disparities, always difference meant inferiority. And it came from many of these very old stereotypes that began in 1619 when Black people first came to these shores. And this is, if you haven't been to the Legacy Museum and Memorial, this is a sculpture from the Memorial Garden. And I always look at this and think, it just sort of says it all, because these stereotypes that began during that time and justified cruelty, unpaid labor, forced labor, still remain floating around today, but they began to explain physiological differences. The one I looked in the 1619 project was that Black people have some kind of superhuman pain tolerance. Again, obviously validated by science. I'm using quotes, science, to explain what these racial difference. It was grounded in the work of the so-called father of modern gynecology, J. Marion Sims, who practiced in Montgomery, Alabama. That, of course, you physicians know that that's the Sims speculum, so it's still named after him. But he practiced in the 1800s, mostly in Montgomery, Alabama, and he was trying to figure out how to repair a fistula. And what he did was he operated on enslaved women, and there were 3 of them, Anarcha, Betsy, and Lucy, that he did most of his work on. And this picture is a famous painting, but it really isn't real. Because I read his biography called My Story, and in it you can see that he, without any shame or reticence, he worked on these women without any anesthesia. And they certainly wouldn't have been clothed on that table. And in the book, he described how the other 2 enslaved women, whoever he was operating on, they would have to hold the woman down because she was in so much pain. And when I'm looking at this, I just kept thinking, this guy is operating under the idea that Black people have a kind of superhuman tolerance against pain. Now today, this is a 2016 survey of medical students and residents out of the University of Virginia, and it asked about certain myths. So about aging, about nerve endings, about brain size, about Black skin being thicker, but also about pain tolerance. And it found that at least 40% of medical students and residents believed at least one of these myths. And 2016 isn't that long ago. This is even more recent, and it was a study of C-sections out of the University of North Carolina, and found that Black women, even when complaining more of pain, got less pain assessment and less pain medication. And I contend that part of this is because of this myth that has lasted from 1619 to now, that Black people have a high pain tolerance. I want to circle back just to that idea that there was a preterm gene. And these are 2 Chicago neonatologists at the University of Illinois at Chicago, Dr. David and Dr. Collins. And they got kind of obsessed with this idea, like, is there a preterm gene, and how to prove basically that there wasn't one. And I really like their research because it's very straightforward and easy to understand. And I put the citation there so you could find it. And what it looked at was, they looked at tens of thousands of birth certificates over time in the Chicago area in 4 groups. One is Black American women, white American women, Black immigrants from some of the poorest countries of Africa and the Caribbean, and then white women from Europe. And in the first round of looking at the birth certificates, they found that the 3 groups, Black women from immigrants, white women immigrants, and white women, American women, all had birth weights of their children around the same size. Only Black American women, their children were smaller. Then they looked at the next generation of those who had, were women and who had a baby. And in the next round, white American women were the same. Immigrants from Europe, their babies were slightly bigger on average. The Black American babies were still underweight. And then in one generation, the women from the poorest African and Caribbean countries, their babies were matching the African American babies. And I was drawn to this study because of the quote that went with it. And this was from Dr. David, who is, a researcher. He's a serious person. And he said, there's something about being Black in America that is bad for your baby's birth weight. And usually, and then he went on to say that something is racism. And usually, if you're a researcher, you don't talk that bluntly. And I was intrigued and got to really know their research and got to know them. So if it's not genetics, which has been disproven, it must be the fault of you, something you're doing wrong, or something wrong with your culture. And that is a large explanation. And when you look at studies, they sort of talk about, it starts sometimes with lack of access, but it really turns into not eating right, not taking care of yourself, not doing the right thing, especially during your pregnancy. And certainly, this is a slide that I got from Dr. David Williams from Harvard, who I really admire and is, a leader in this space. And he talks about how people believe that the solution to all kinds of inequality is more effort. But even I contend that even as Black people, when we're trying our hardest, still, as a demographic, these racial health disparities don't change. And certainly everybody should do their best, and we should be like Michelle Obama and just move and exercise. But what if there's something else going on that is not necessarily the fault of individual people? And where does the assumption that something's wrong with the Black culture or something we're doing wrong, again, comes from enslavement. And it's the idea that stereotypes were meant to dehumanize and demean people in order to build wealth in our country. Stereotype 1 is that Black people are angry, violent, dangerous, and lack intelligence. And this stereotype is especially heaped on Black men. But there's a consequence and a price of that stereotype, and it's this. It's this, which it sounds like you're going to talk about. It's the Tuskegee experiment, which recruited Black men in Alabama to take part in a syphilis study that left syphilis untreated and left them to suffer under the idea that they had bad blood, and also that under the idea that they were not feeling pain the same kinds of ways, and as Dr. King might have said, were inhuman. And finally, this is the price of the stereotype. The stereotype for Black women mostly is when the intersection of gender discrimination and racial discrimination is that Black women are angry, hypersexual, and irresponsible. This is a cartoon of Serena Williams at the US Open a few years ago when she argued against a call. And this was the image of her. That image has a price. The stereotype has a price. Several years ago, 2017, when her baby, she went into the hospital, pregnant to have her first child. She had the best healthcare. She's really rich. Her husband, who started Reddit, really rich, but still, she did not get equal healthcare. And when she voiced her legitimate concerns about what was going on with her, she had an embolism, which she understood how to treat. She was ignored and shut down until it turned into a crisis. And she ended up basically on bed rest for weeks and weeks after her pregnancy in a way that was unnecessary. And this is the price of the stereotype. This is Dr. Susan Moore, who in 2021 was a physician in Indiana, got COVID, went into the hospital. And when she talked to the healthcare providers about what was going on with her, they shut her down. She had extreme pain in her shoulder, and she asked for pain management. And what she said was she didn't get it right away and was made to feel as though she were drug seeking. She made a video. This is a screenshot from her Facebook Live video, where she was talking about her treatment. And the refrain, she said, is, "This is how Black people get killed." And she talked about what was happening. This is how Black people get killed. She ended up leaving that hospital. She died of COVID in December 2021. And in the investigation of the hospital system in Indiana, they found out, the investigation uncovered that part of the reason she did not receive the kind of treatment that she deserved was because some of the healthcare providers were intimidated by her level of medical expertise. So it was alarming that being a doctor was actually harmful to her. And when she tried to speak up, she was shut down, I think, because of the stereotype that was making her seem not sort of in pain or suffering, but angry and dangerous. So the newer explanation to explain these racial health disparities is not that there's something about race or being Black that is bad for the body, or something wrong with Black culture, but it really is racism, race as a risk marker for discrimination, ill treatment, disruption, fear, and stress that both shortens lives and affects pregnancy and childbirth. And this is what the basis of my book is, and that's why I talk about racial health disparities are related to not just healthcare, but health. And I'm just going to go through the three things. Battling discrimination creates a kind of wear and tear on the body. Centuries of sanctioned discrimination has made Black communities less healthful, and proven racism in the healthcare system harms Black people and others. The first is the idea of weathering. And weathering is a concept coined by Dr. Arlene Geronimus, who is a professor at the University of Michigan in the Department of, I think she's in the Public Health Department at Michigan. And her idea is that battling discrimination day in, day out creates a kind of toxic stress that accelerates aging. And she has studied it for years and years. And it was interesting because for so long, when I first interviewed her in about 2018, it was really easy to get in touch with her. She hadn't been listened to most of the time, and her ideas weren't lifted up. But after the pandemic, when you saw these rates of COVID much worse in a younger demographic of Black people compared to white people, not suddenly, but over time, her theories had taken hold. And I'm really happy that next month, her book Weathering will come out. And I'm really proud of her. And I think that there's a greater acceptance of this idea that something about the lived experience of being discriminated against in America, and Black people have just been discriminated against and treated poorly longer and worse, creates this kind of accelerated aging that makes sense and that at least we can understand. It feels personal to me that tall curly-haired person is my daughter. I was pregnant in 1997, and I had a great physician. I was at Mount Sinai Hospital here in New York City. My doctor, my OBGYN, was my really close friend. My first child, I go into the doctor's office, and we're both shocked that my pregnancy is going really badly. I got put on bed rest. I got sent to a specialist because I had intrauterine growth restriction. I didn't understand it very well at the time, but what I did understand was that I was shocked because I was taking such good care of myself. I was the health editor of Essence, so I was like the public persona of good Black women's health. When I got to the perinatologist appointment, the person sat me down and said, "Well, what are you eating?" and went through a whole litany of soul food items that, I only basically eat on Juneteenth, and said, "What are you drinking?" and went through all the liquor I could possibly be drinking. I was like, "I'm pregnant. I'm not doing that. And I never would be." And it's like, then it's, "What drugs are you using?" And it was every single drug: pot, crack cocaine. "Are you doing this? Ecstasy?" No, of course not. And then I realized later and talked to my own physician that uterine growth restriction is so rare in someone as healthy as I am. My baby was barely not preterm. I basically held her in for that extra day so she wasn't preterm on paper. She was born at 4 pounds, 13 ounces. I could hold her in the palm of my hand. No one else wanted to hold her because she was so small. Now she's fine. That's her. She's good. But I always wondered, and I've now known so many other, Black women of all classes who have had this situation. And I've always wondered, was something about my lived experience related to my baby birth weight? And, I'm a petri dish of one, but I always have wondered that. The second thing is the so-called social determinants of health. And I say so-called because it doesn't seem like a very good name. When I talk about it to people who aren't in the field, they're kind of like, what is that again? And I basically say, no, it just means it's a way of a jargon for the environment. So that the environments that Black people and other people of color live in are less healthy, lacking access to healthy food, clean water, clean air, safe space, education, jobs. And that's also personal to me. My family came up from Mississippi to Chicago during the Great Migration, my grandparents and all their siblings. They landed in Englewood, the Englewood section of Chicago. In present day, people in Englewood only live to age 60. 9 miles north, they live to age 90. So there's a 30-year gap in life expectancy. It's the largest in the country. I was in that neighborhood until I was 10. I thought of it as a beautiful place with where my mother went to elementary school with Gwendolyn Brooks and Lorraine Hansberry, where my grandparents were very successful. They owned a home, and my great aunts and uncles had their own businesses. But when I went back in 2020, I was surprised about the erasure there. The place where my grandparents first settled had police tape around it. My mother's elementary school was basically in a condemned building that was closed. And everywhere we went, we kept seeing, it looked more like Mississippi than in the middle of Chicago. And when I looked into it, I wasn't surprised that the community and almost every community in Chicago and many Black communities around the country are redlined. So that meant that Black people couldn't get mortgages at the time when my family was there. But Chicago went a step further to fill in the gap for Black people, all these people coming up from the South who couldn't get mortgages. They created contract buying. So contract buying meant that if you were Black, you were able to get a home, but the price was inflated, the rate was inflated. And also you could only own your home on a contract. You couldn't really have any equity in it. So if you missed a payment and lost the home, you lost it. You didn't have the equity. You couldn't pay it off. You couldn't own it until all of the payments were made. And I remember asking my mother, I said, how did grandfather own that building in Chicago? And she said, I don't remember. He got it on some kind of contract, and he always terrified that if he lose it, we'd be bankrupt. And I always thought of that. And when I looked into it, I saw that contract buying sapped out $3 billion of Black wealth. So if you can't have wealth in a community, you can't have an accumulation of assets, you end up without good health. And then the final thing, the final concept is discrimination in the healthcare system itself. And I was on a panel a few weeks ago at a fancy medical school in Boston. You can imagine what it is. And we were having this conversation. It was a doctor on one side of me, a doctor on the other side of me, and me. And we were talking about discrimination in the healthcare system. And one of the doctors turned to me and said, well, people like you should just do more research on this. So we really have enough evidence. And I don't really get that emotional, but I just burst out and I said, we don't need any more evidence. And I pointed to the 2002 National Academy of Science Unequal Treatment Report that looked at 483 studies. And it found without a doubt that there is clear discrimination of healthcare systems and in the healthcare system among Black people and sometimes other people of color. In fact, Dr. Schulman's study is one of the 483 studies in that report. And it's without a doubt, this is the 20th anniversary. Last year was the 20th anniversary of the study. This year is the 20th anniversary of the publication of it. I hear that there's going to be a second look at it, but it is considered the gold standard about discrimination in the healthcare system. This is personal to me. That is a picture of my father, who was a veteran. And when I was pregnant with my second child in 1999, I was working at the New York Times newspaper. My mother called me and said, you need to come home from New York, come home to Denver, where I spent, most of the rest of my childhood. You need to get on a plane and come now. I'm pregnant, so I'm really not trying to get on a plane. But she said, you must come. I'm going to meet you at the airport. You will put on your really nice business clothes and put your business cards from the New York Times in your pocket. So I came home. My mom met me at the airport. She was really dressed up. And I said, Mom, what is happening? And she said, your dad is much sicker than he has let on. He is in the hospital and we have to go help him. And I said, why? Does he need help? She said, they're treating him like an N-word. And she said the word. So we went to the hospital, and my father was an impeccably dressed person. He was trained as a bacteriologist. He worked in hospitals in some of his life. He was kind of quiet. His favorite thing is fishing. So he's very patient and he's easygoing. When I got there, he was in this dirty gown. His hair was really disheveled. He was really agitated. He was very upset. He was better when we came, but I leaned down to him and I said, what's going on? And I realized he was restrained to the bed. And my mom knew what to do. We went home and we got his medals from military service. We got his degree. We got pictures of him before he was ill. We came back and we explained to him that he was trained in science. If you explain things to him nicely, if you are kind, if you're patient with him, he won't be so agitated. But seeing him there, I just thought, how could this happen to my father, who just gave everything for his country, who gave everything, who believed in the system? And I just thought, this is because he's Black. It wasn't until we proved that he was respectable, that he could get treatment and care. And I just kind of never forgot that point. So finally, I don't want to end this slide presentation with all negative. I think there's a lot going on. There's a lot of change. There's a lot of change even with what you're doing there at Stanford Medical School. And it's important, the work you're doing. This is Dr. Mary Bassett, who until recently was the Commissioner of Health in the state of New York, formerly the Commissioner of Health in New York City, who mandated anti-racism training for all 7,000 employees of our city health department in New York several years ago. But I love this quote that was in the New England Journal of Medicine about 8 years ago, which says that if you're working with Black patients, you can't just treat people, you also have to fight anti-Black racism. This is, you probably all have to deal with it, know about this, or at least some of you may have to deal with this. This is happened in 2019 after your state really made a lot of progress in infant mortality. But the racial disparities didn't change despite, innovations in the healthcare system level. This is, mandates that people working with birthing people must go through some kind of anti-racism training. I'm very interested in what has happened since 2019. Unfortunately, the pandemic got in the way of progress, I'm sure, but I'm interested to see what's happening in your state since this has passed. This is White Coats for Black Lives. I'm pretty sure you have a chapter there, which is medical students who are trying to make a difference and trying to be different kinds of doctors and doing the work that you're doing there. This is Institute for Healing and Justice in Medicine. It's at UCSF, and it's students who are studying medicine there with getting their joint degree, their MPH at Berkeley. I really like this group. I've had them speak to my students. I covered some of their work in my book, and it's medical students who are really trying to, on a national level, to make a difference in as far as racial health disparities in society and healthcare. And I'm really interested in what they do next as they moving from medical students to physicians. This is, these are activists in New York City that were protesting for about a year around the statue of J. Marion Sims that was across the street from the National Academy of Sciences in Central Park. It got taken down partially because of their sustained protests. J. Marion Sims statue is still up in Montgomery, Alabama. So if you go to the Legacy Memorial, the Legacy Museum, there is a counter protest. This is the one with the red glasses, is Michelle Browder, and she created a sculpture for Betsy, Anarcha, and Lucy. that is the Mothers of Gynecology. It's beautiful. You can walk from the Legacy Museum to her statue garden, to her sculpture garden. There is also a book about Anarcha that one of the enslaved women that looked at her and calls her the mother of modern gynecology. It's coming out in about a year. And then finally, I taught pre-med last semester, and these are my students at CUNY Med School who had to read my book and had to once a week, we talked about these issues, and I saw them really hungry and to be a different kind of healthcare provider in the future, to really open their hearts and open their minds, and to also overcome the odds in some of their families. They were all basically first gen in America or Black Americans. And I was really proud of their commitment and their own progress. I'm going to end now. And take any questions you may have for me.
Great, thanks so much. Really amazing, powerful talk, and it's a great journey through the book. And thanks for sharing your personal story in the book and here today. I think stories mean a lot. We look at data oftentimes, we look at areas under the curves. We're easy to look at figures. It's much harder to deal with stories, and it's much more powerful way of convening, conveying the same information. So thank you very much for doing this, and thanks for joining us today, being surrounded by all these people with white coats. Although we don't wear white coats all that often at Stanford. A couple of questions have come up. One question is, one of our physicians said, I've felt the visceral distrust of healthcare from some of my Black patients, as you mentioned at the start of your talk. What strategies would you suggest for me to start to address this?
I think it's hard. I think it's hard given the current healthcare system, the way you're kind of forced to work with limited time and often in a stressful situation. But I was speaking at Temple Medical School, and it was really interesting. It was one of the medical students raised her hand, and she was saying how she was seeing how there was a patient that they were working with, and she was the student in the room, and she was seeing that the patient was distressed and distrustful and scared, and she was noticing that the other healthcare providers weren't paying attention and may have actually been low-key making it worse. And what she did, and I said, what did you do? And I was thinking, poor thing, that's very hard because you're the one with the least power in the room generally, except for the patient. And what she said was she focused on the patient, and we all stood up and applauded her. And I do think that another thing that happened, I was speaking at Northwestern, and a woman ran out after my presentation, and she was a sort of an older medical student, and she had tears in her eyes. And she said that she was a former third grade teacher. She came to medical school, and she was thinking she would bring some of the skills she used working with her young students to her practice when she's I think she was a third year medical student getting ready to go into, the next round. And she was afraid because she said medical school is really kind of beating out of me the things that I learned as a teacher. And I thought about those two things. And I think that, on the short term, I think as healthcare providers, there has to be a kind of, more effort putting in more effort around being slow, being thoughtful, like the care I wanted for my father and in all of his fear. But I think in the long term, there has to be a kind of abolition of the way healthcare is taught and also how it's practiced, so that there is more empathy, even though obviously everything costs money. But I think we get so fearful because it's sort of like, I think of what happens in places where a lot of innovation and money is spent on things that aren't, are certainly good and life-saving, but we forget that there are sort of more inexpensive ways to make the experience of healthcare better for people, and it may ultimately make health outcomes better.
Great. Well, thank you. Dr. Dunn has a question.
Thank you so much for that amazing talk, Linda. We really appreciate it. And, as someone who had a 4-pound baby myself, I feel a connection, and that a lot of what you said resonated, of course, and speaking and thinking about my own story. But I really thank you for sharing your stories with us as well. I think it's so important that you are changing the way that medical students learn. I think it's incredibly important for them to get the entire story. And I'm glad that your students read your book. I think all students should. But I do wonder, after watching the State of the Union, of course, and the response to the State of the Union, how do you propose we deal with those who really think that learning about this is just part of wokeness, and really they try to combat it and just don't support these teachings in schools? And the second question I have for you is, what do you do to practice self-care in doing this kind of work, which I know can be traumatic, frankly, sometimes?
That's right. I think, to answer your first question, I think the horse is kind of out of the barn. And I was reading about what was going on in Florida with the AP, the African American Studies thing. And I looked at, they got so much pushback, but still they shoved something in, like I didn't love that they took out some of, the really good, why you're taking out Angela Davis and Bell Hooks, those are really, we should be reading them in a, and not just for the Black stuff, there's stuff that is very important as in American history, and society. However, something got put through. There is something there that can be taught, and it's been institutionalized. So what I do is I'm super half glass full. So I'm always focusing on what's being done and what's changing. You here are tomorrow, you could be talking about the 1619 project. That is amazing. And there's still, work that's being done despite what is going on with the, in other parts of the country or other communities. Where I grew up in Denver is, it's purple would be the kindest way to say it, but it's kind of like not, it's more red. And I went back to my high school reunion this year. My sister, all my family said, don't go back. They're so mean to us in high school. But I did go back, and I was really cheered when I saw that some of my high school friends had read my book or wanted to talk about it. And, that was how I grew up. That was not the case, and wanting to engage in some of the ideas. And so I did it gently, I did it as best I could, to keep that door of conversation open. Things like that can be weathering for someone like me or anyone who's doing that. And I am kind of don't bring it home. I think of you all as physicians too, having to deal with this. And, I don't internalize these issues. I am very positive. I keep looking toward the light, looking toward hope. Knowing that my work is making a difference. Don't internalize the things that, especially the stories of people that are traumatic. I listen with compassion and empathy, but I don't take it home. I have a calendar. Basically, I'm counting down the next 6 weeks because April 1st is the beginning of trout fishing season. So I will be up in upstate New York on the first day, April 1st, trout fishing and hiking. I have a dog I really love. I take good care of myself. And, because I feel like if I don't, then I won't be able to do this work. I'll be tired and upset and angry. And that doesn't feel right.
So we'll take questions through the Q&A if people have questions. We have another one just came in. On the education side, you talked about some work I did a long time ago. At the time, only 5 medical schools in the country, I think, had some kind of curriculum to address, cultural competencies. I ended up moving to Duke, living in the Deep South, where people my age went to segregated elementary schools, and our medical students came from all over the country. They would never know, they didn't even know the South had been segregated, and it was a huge issue with older patients not even knowing their history. And so, what do you think about education? How much should we teach about the history that you talk about? to put all this into context? And is that helpful, do you think? And are there other skills, like as you're working with your pre-med students, are there things, that we should be thinking about as we develop our education programs here?
Well, I think there is great value in teaching about history. And I think even as we're locked in this battle over sort of wokeism or all this, stuff, when at the, before the 1619 project, there was so little history taught that it, basically was so watered down or erased. It was nothing. I remember I learned, when I was growing up, I learned about slavery through roots because we got nothing in high school in Denver. Then I went to, my children grew up here in Brooklyn. And I remember we went to Gettysburg on the field trip for the fifth graders. So I was like, oh, this is great that this is the beginning of the speaking about the Civil War. How are you going to teach about, the Civil Wars in the South, basically? How are you going to teach about that and slavery? And the teacher looked at me blankly, and these are my children. So I think I was really excited when the 1619 project came out. What I saw was a huge response from teachers saying, thank you for giving us something to ground ourselves in when we teach about the history of, race and racism in America. And I saw that gratitude. And I think, at some point, people want the truth. They want it. It's I think it's been made divisive, but I think we have to keep pushing for this. And I really saw with great joy, how my pre-med students reacted to this. And I've spoken a lot at medical schools in the past year around my book. And, it's really exciting. When I can't remember where, maybe it was at Temple, where two young Black men came up. They were medical students. I think they were third year. And they came up and they were in a class. They had just been in a class. This is recent. And they were teaching about kidney function. So they raised their hand and they asked about the race correction for kidney function. And the professor was just saying, no, this is just a thing. We've always done it. This is why. And they were talking about the fact that Black people as a group have more muscle mass. Now, remember, this is recent. This isn't just in the last month. And so the students asked, clarifying questions. And they said, well, if the white person is Arnold Schwarzenegger and the Black person is Barack Obama, then how could how are we using muscle mass as in a demographic? So, it's hard to push back against your professor. And the two ended up walking out in protest. And now the school, part of what the school is doing is reevaluating some of the texts. So I think teaching about it opens eyes and opens minds. And, it's just a process. Same way children learn differently, people change differently. And I hope I don't seem like, I was born with this knowledge. I'm like 64. I just had my 64th birthday. I've been trying to figure this out along the way myself. And I thought that individual behavior was the key. I understood that there was something genetic going on to understand racial health outcomes. It took all these things and years of studying, interviewing, really reading and working on this to sort of come up with these, the basis for my book. So I am super greatly sympathetic and empathetic to people as they work to change their minds, because it's hard to change your mind. But I think the more we educate people in whatever way we can, the more minds will open.
Great. Well, we have one question going back to the kind of genetic concepts and weathering. Is, at least from the weathering perspective, has anyone looked at epigenetics and whether there's actually biologic impact of the weathering?
That's super interesting because people always ask me about epigenetics, but it's funny because they also ask, what is the one regret you have about your book? And I think the two regrets are that it came too late to really lean into reproductive justice very much, because it came, when Roe v. Wade went down, I was on my book tour. And then the other thing is that I didn't do a good job with epigenetics, which I do agree with, but believe in, but it's in the book Weathering, which coming out next month, please get it, Arlene Geronimus. She talks about epigenetics and the way sort of the kind of racial insults and the impact of discrimination can land on the body and make a change the genetics of a person, that like, hello, I'm not a scientist, but I did read that with great interest to see that she was discussing it in the book. So go to a person who knows more than me. If I ever get an assignment to write about this for the Times Magazine, I will know everything because it takes me so long to do these stories. But I don't know that much about it now, but I know that there's a growing interest in that area. And I think it is related to, some of these concepts.
Kind of a different question. This is Stanford. So before COVID, there were only 2 lectures at Stanford. One was machine learning is the future of everything, and the other is machine learning is incredibly overhyped. But but now we're post-COVID and back to machine learning again. And so one of the things that we talk about a lot is that machine learning uses the data that's available to come up with its answers, especially kind of this ChatGPT. What do we do to protect us from propagating all of these harmful interpretations as we use this technology that's kind of agnostic to understanding the value of different sources?
I think it's really hard because everything technical is really sexy. And it's tempting to just go down that route. I think you have to force yourself to remember that people make machines and people are not perfect and people are flawed and make mistakes and have biases that they may not understand or generally don't understand. So I think that going down that path of, so focused on sort of technical, even clinical innovation is a mistake. Obviously you should do that but I just keep thinking of that Martin Luther King quote, inhumane inhumanity. We have to remember the humanity of people is far beyond anything we can do with a machine. And I was at a medical biological engineering conference with my friend who is a Black woman engineer, and she invited me to speak. So all these these engineering students came up to me and they all had their phones. Look at this app I'm creating to solve medical inequality. And I'm like, just listen to my lecture first, okay? Before we start to dive in and you show me all these apps on your phone or whatever, because I think it has to always be two-pronged. We can't just focus on one thing without understanding that there just always needs to be a human touch and a personal touch in medicine, and not to forget the importance of that.
Great. Well, let me, a bunch of people are asking questions about motivating them, that they're motivated to act by this, that, the talk has really resonated, and lots of compliments that this has really been profound. What should we do? Or what should each of us as individuals do and think about?
I think that the first thing you can do is just reflect. And I think it's important to reflect. And I mean, in great humbleness, that's what I've spent my career doing, is reflecting on what I used to think and what I think now and how I used to be and how I can motivate my own self to change and be better as a journalist and think broader and even find different sources and find different things to read. So I think you're on the right path, the work you're doing. I think it would be profound if you could have a connection with the Institute of Healing and Justice in Medicine. Those are medical students really trying to make a difference. And some of the things that they're doing are super innovative and interesting. But I can tell that they need support. I think you can also listen to to the students that you work with at your medical school. And I think much of the change that I've noticed around the country has come from the so-called bottom. It's the students themselves who are pushing back, certainly in New York at Mount Sinai and some of the other hospitals, Montefiore. You saw that, where the students, maybe they took a class with someone like me, or they took a class with, like that. And then they said, wait, we want to do things differently. So I think that is important. And I think you can just keep reading and keep opening your mind to learning. And, I think that would be profound.
Great. Well, I'm cognizant of time, so this has really been a fantastic hour. Thank you so much for sharing your experience, your your thoughts and your journey with us. And we're really very, very grateful. So
And-
thank you very much.
Well, I appreciate the opportunity, and I also, Kevin, appreciate you and all you've done. And thank you. Thank you for inviting me.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.